Thank you, Jacqueline. Very appreciative and welcome everyone. Thank you for being here. This is not a super exciting program in a lot of people's minds, but it is in my mind because we have so many skin tears in our elders and people that are on steroids for long periods of time. We have them in our neonates. So skin tears go across the continuum of age and certainly across the continuum of care. If you haven't met me before, my name is Pamela Scarborough. I'm a physical therapist, a wound specialist with a very extensive background in both physical therapy and wound management. And I have the privilege and the honor to this day to teach people from every credential level, my CNAs, my surgeons, my physicians, my nurse practitioners, my physician associates, my LVNs and my LPNs. I have the honor of teaching every level of licensure. And I'm so grateful. I saw a PT on here. We don't get a lot of PTs on here. I'm so grateful that we do have one because physical therapy has a big role in wound prevention and certainly in wound management. So with that said, let's get started on skin tears. I do need to read you this disclaimer from the company, United Wound Healing. This information is provided for informational purposes only. Patient care decisions should be based on relevant clinical guidelines, including current evidence-based literature, state and federal guidelines, such as from CMS F686, F684, F880. These are three huge tags that go along with wound management in the post-acute long-term care setting. Decisions for wound management should be based on a holistic review of the patient's clinical condition. You don't look at the hole in the person first. You go and look at everything else about that person before you call me up and say, Pamela, what dressing should I use? I don't want to talk about the dressing. I want to talk about the whole patient, what caused that wound, what needs to be intervened for systemically. Then we're going to talk about that hole. The clinical team members are encouraged to rely on your training and expertise in wound prevention and management. Where did you get your training in this? How is it that you are considered an expert? Because you need to know how to do wound prevention and management, as well as all available clinical and other pertinent information prior to making treatment decisions for any individual patients. Carrie Sussman, 1997. Look at the whole patient and not just the hole in the patient. That's what that was about. So we're going to talk about preventing skin tears wherever they may be located. We're saying here in facilities because we do a lot of post-acute education. We're going to talk about the International Skin Tear Advisory Panel that put together a guideline and algorithms for you, and you're getting these documents to help you to prevent your skin tears in your facilities and home health, wherever you may be working. And you want to talk about, be able to verbalize some of the prevention and treatment parameters that we look at when we're talking about skin tears. So these are the handouts that have been, that will be available to you. Jacqueline will be sending you that. She's told you this a couple of times. You're going to want to use these documents to help you to create a program in your whichever care setting you're working in to help prevent and care for these skin tears. And this is one of the documents. It's an updated document that came out in 2025. So this is going to be coming to you. There's also a skin tear advisory panel. It's an international panel that really does work on this. And it is an international problem. It's certainly not just here in the United States. So when we look at skin tears, they can be equal to or greater than pressure injuries. We really don't know because we track pressure ulcer injuries, but in general, we don't track skin tears, which should be tracked so you know where they're happening in whatever type of location you're working. Common across all care settings, affects all ages. I talked to you about the neonates. Their skin is very fragile when they're first born. And if they're early, their skin is super fragile and they can get skin tears, they can get pressure injuries, even our neonates do. And in the aged, it's really on the extremes of age, neonates and aged, where we see most of our skin tears. In the middle, if people are younger, it's usually because they've been on high levels of steroids and their skin has thinned over the years that they've had to take those steroids. These are painful wounds. They're acute wounds when they first start out, but if they are not cared for appropriately, they can become a chronic wound. There can be complications such as pain, infection, and delayed healing. These are largely preventable if we think about what we are doing carefully. And the people that are handling the patients, if they think about situational awareness, that's something that comes out of flight schools and flight training, situational awareness. Well, I have to tell you, situational awareness is important in every situation in life. So the definition of a skin tear is a traumatic wound caused by mechanical forces, including removal of adhesives. You've seen, done, watched somebody take off an adhesive, and there comes that top epithelial layer. And patient handling, when we're not handling our patients with intent, with awareness, with situational awareness. The depth of that skin tear can vary depending on whether or not it's through the subcutaneous layer. So this is from the new definition of a skin tear from 2025. And what you're seeing here is a large partial thickness skin tear that's been separated the epidermis from the dermis. Now, it's no longer considered, and this is an international statement. Wounds are no longer designated as a skin tear if the tissue damage extends beyond the subcutaneous tissue. So if this becomes full thickness and it goes down to muscle, that's not a skin tear anymore. If it gets infected and gets deeper, now it becomes some other type of wound. It should be described according to the underlying cause of the tissue damage, such as the etiologic. Now, this is a European document, so they spell things a little bit differently. I didn't misspell this, but you might be seeing some European spellings, such as the etiologic or pathophysiologic origin, mechanism of injury, or other appropriate classification system. Deep tissue involvement reflects more extensive damage and exceeds the anatomical boundaries that define a skin tear. We want to look at our skin tears meticulously, and you need to know what you're looking at, and you need to know the layers of the skin. So when we look at the wound depth, if it extends, the extent of tissue damage goes through the skin's anatomical layers. If it goes through the subcutaneous tissue all the way down, it could be considered a full thickness wound. So, and it's going to differ. The anatomical locations on different parts of the body are more susceptible to full thickness or partial thickness wounds. So of an aged patient, thin skin on the shins can mean that skin tear is not deep, but it's still severe. So you look at the anatomical location, situational awareness. Is the bone right there? Is it the gluteus maximus or part of the arm where we do have tissue, or is it where it just goes from skin right down to the bone area, such as on the top of the shin, on the anterior surface of the shin? Skin tears, they are traumatic wounds. There has to be some mechanical force that took place to have a skin tear, such as it could be from shearing. Friction is very common. Blunt force trauma is common. Falls. When the person falls, oftentimes they injure their skin. Poor handling techniques, and we need to be careful with our jewelry and our nails. We cannot have long nails. And I'm hearing we're having long nails in long-term care. We can't have those nails. We have to keep our nails short, so that we don't hurt the skin of the people for which we are caring. It could be from equipment injury, removal of adhesives, we've already talked about. And we need less force. Look at this bullet. Less force is needed to cause traumatic wounds, skin tears, in our very aged individuals and our neonates. And the incidence of skin tears increases with these two populations. So we have in the definitions of skin tears, it goes even deeper. I hope you can find a skin tear champion, a skin tear prevention champion in your facility, and that you can have a skin health champion, which would include your skin tear champion, so that you're always thinking about the skin. Somebody's always thinking about what's happening to the skin. So in our definitions, we can have uncomplicated or complicated skin tears. The uncomplicated, they're usually acute wounds, and they're going to fully re-epithelialize within about 4 weeks. So that's what you're seeing over here on the left. It's a potentially uncomplicated skin tear. It's a partial thickness wound. And that flap that goes over the skin tear, this is the pedicle. This is where it's attached to the skin. You want to know what your pedicle is. You want to know what your flap is. Can that flap be repositioned by gently pushing this back in place with a saline moistened cotton tip applicator? And then we have the more complicated. They're going to be more complex, especially in the lower extremity. And that's what you're seeing here is a skin tear over the Achilles tendon, where we have very poor blood flow oftentimes in our aged population. So this wound is at high risk for being a full thickness complicated wound. It started out as partial thickness, and that flap has been mostly repositioned. It is over the Achilles tendon. This is an older adult, and they do have peripheral arterial disease. So you have a skin tear like that. One of the things you want to know is, What's their blood flow like for wound healing opportunities? And just because somebody bleeds does not mean they have good blood flow. Bleeding does not correlate to good blood flow. So the scale of the problem, data tracking, we don't know. Kind of like pressure injuries. We don't have many pressure injuries. Now, people say, Pamela, you're crazy. We do. We report them. We count them. No, you don't. You don't know if it's a pressure injury, an atypical wound, or if it's skin failure at the end of life. And we're reporting all of those as pressure injuries, by the way, which we did a course on that a while back. So it varies. The number of skin tears vary across the care settings that we're in. We don't have good data. We don't have good clinical data. We don't even know the financial impact of skin tears, but because we don't collect that information. We collect what CMS makes us collect, but we don't oftentimes collect some of the things we need to collect to take care of our patients from our perspective, not just from CMS's perspective. Many of them are preventable. When we have skin tears, they take up a lot of nursing time, a lot of our CNA time. There's financial cost that goes along with it and discomfort to the patients. So accurate tracking of skin tears prevalence strengthens data quality, clinical practice, and documentation. And then here is another partial thickness skin tear that you see over here. And this is looking at the prevalence and not long-term care. And we don't know. It says 2.23% to 92%. Is the estimate for long-term care skin tears. Community home health, 4.5 to 19.5%. Palliative care, 3.3, 14. Acute care, 6.2 to 11.1%. So it's all over the place. It's all over the place when we look at tracking our data. The identification, there was an international survey, and it was very interesting. This survey was interesting because 70% of the people that answered it reported that there was a problem with their current assessment and documentation of skin tears in their clinical practice. So I have a question for you, Melissa, Adrian, Tanya. Do you think there is a skin tear reporting problem in any of your facilities? Please say yes or no. Is there a skin tear recognition and reporting problem in your buildings? Yes or no? And Jacqueline will tell me about that in just a few minutes. 90% of the people that took this inquiry, this questionnaire, 90% favored a simple method for documenting and assessing skin tears, which is where we're going in a few minutes. 81% admitted that they don't have any tool or classification system. And my question to you, the audience, is do you have a classification system for skin tears? Because if not, that's exactly what we're going to cover in a few minutes. And then 40% admitted to ignoring or not documenting anything on these wounds. Now, these were not transparent questionnaires, and so you could answer your transparently. 40% admitted that their facilities, their care setting has no methodology for really documenting these wounds, or they ignore them to a certain degree. So your risk factors for skin tear, there's 3 general risk factors. This particular document, there's a 2013 rendition, a 2017, and we just got a 2025 rendition, which is the one that I just gave you. And these are some of the same things. The general health, you have to go back for anyone with wounds, doesn't matter what the wound etiology is, you got to go back and look at the comorbidities. You want to look at the polypharmacy. Are your patients on any type of anticoagulants, which could make all of this worse? Impaired cognition. When they have impaired cognition, when our patients have impaired cognition, it can be an issue with them actually hurting themselves sometimes. And then malnutrition. Mobility is a big issue. Mobility is a huge issue. You will have more skin tears in people who are immobile or have mobility issues because we are holding them. We are helping them. Sometimes we're putting equipment on them to move them. The equipment can cause skin tears. The people that are dependent for ADLs, these are the people that are going to have more skin tears. And then the skin, we've already talked about the extremes of age, the youngest, the oldest. Dry skin, as we get older, we lose our moisture producing abilities. Medications, I mentioned steroids, big, huge skin thinner medication. Is that what steroids are? And then if they've ever had a previous skin tear, just like pressure injuries, they're always at risk for another. So this document has been provided for you, and this is your skin tear risk assessment pathway. So we have people that are at risk, where they have more than one or more risk. that are listed above. Here's some of your risk factors. What I just went through with you, your general health, your mobility, and the skin. So we have at risk and we have high risk. So at risk on this document is one or more risk factors up here. And then high risk is where you add these things: visual impairment, impaired mobility, dependency for activities of daily living, extremes of age, and previous skin tears. And then there's, if you're creating a skin tear prevention program, this is some of the information that you're going to use for how you're going to set it up. And this is a quick reference, guys. I'm not going to go through this. I'm showing you this document. It is important if skin tears are anywhere on your radar for your care setting, for your company, for your patients and residents. These documents are important. So I'm not going to go through every bit of this with you, but I wanted you to see it. So skin tears, this is a risk reduction program checklist. We even have a checklist for you if this is important to you, to your building, to your patients and residents. And this is a checklist that you might use. So that's in this document also. So your risk factors, we have our extrinsic risk factors, intrinsic, things you can't change about yourself. Your age, it is what it is. Gender, females in general have more fragile skin. In general, and it has, part of it has to do with our hormones. I'm not sure what else it has to do with as being a female. Caucasian, people who are Caucasian, also known as white people, those people are at higher risk for skin tears. Nutrition and hydration impairments, cognitive impairments, and immobility. And then we have our extrinsic. Handling. How do we handle people? Do they have falls, donning and doffing their stockings, adhesives, and again, the drugs are the steroids. And this is showing a skin tear in an older adult, and this is showing a skin tear in a neonate. Mobility related, most of these are related to mobility or immobility or inability to move freely and easily. Could be wheelchair injuries during transfers. We mentioned falls. I was talking about transfers, holding their arms, people with fragile skin, blunt force trauma where they bump into things. And most, look at this. This is important. This is so meaningful to you. This is something you want to know. What time did that skin tear happen? Most skin tears happen between 6 a.m. in the morning and 3 to 9 in the evening. What's happening? What's happening at 3 to 11 in the morning? And then again, 6 to 11 in the morning and then 3 to 9 in the evening. What's happening? Put it in the chat. Put it in the chat. What's happening during these times? There are associated predisposures if these if the person may be predisposed to skin tears, if they have the senile purpura that they can get, senile purpura, that ecchymosis that you see, hematoma or bruising, such as you see here, previously healed skin tears, are edema. Now listen, edema from any cause. It can be congestive heart failure. It can be edema from venous insufficiency or lymphedema. Anytime there's edema, that person is going to be at higher risk for skin tears. And if you're trying to heal a wound, you got to get rid of the edema because it takes more, the blood flow is further away from the wound bed when you have edema. So edema is a wound hindering effect, and you got to get rid of it no matter what the etiology is. And if it's congestive heart failure, we got to take care of the congestive heart failure. So 70 to 80% of the skin tears happen on the arms and hands, particularly in our non-ambulatory patients. The ambulatory patients, when they're able to walk, they usually have more skin tears on the lower extremities. And again, it could happen because of handling techniques, falls, equipment, removing the equipment injuries. And this is a partial, a type 3. We're going to talk about type 1, 2, and 3 in just a minute. This is a type 3 partial thickness skin tear on the lower aspect of the upper arm above the posterior elbow. So that might be how you would talk about that. So again, the skin tears can be caused because of a combination of intrinsic and extrinsic. So whenever possible, you want to document this cause of the skin tear if you can. Now, we do know that almost half of the skin tears have no apparent cause to them. Somebody didn't see them. We have our patients giving us a verbal report on what happened. So we may not be able to precisely document what caused the skin tear, but without this documentation, there's no way to improve our care. If we don't have why they have the skin tear, how are we going to organize our education and our training? So we want to be able to have why they got the skin tear so we can talk about the whys and give the training so that we don't have these whys they got the skin tear anymore. Most common causes of skin tear, and this is just looking at this is blunt trauma is number 1. Falls is number 3, while performing activities of daily living and dressings, number 2, during patient transfer, and equipment injuries such as wheelchairs, side rails, or maybe some other cause in the bed. So when we look at prevention, you really do want to have a prevention. Yes. Yes. Okay. Wake up and bedtime. Somebody said, thank you, Patricia. Wake up and bedtime. That's when most skin tears happen. And what are we doing? It's when we're handling them. So are we part of the problem that can have an intervention and training? So prevention of skin tears, early recognition, that's very important. You want to do a holistic skin assessment. This should be conducted on admission. Nurses, you do your head to toe skin assessment on admission. Then you do it for the first 4 weeks. Then you do it quarterly, or when there's been a change in condition. So you know when you do your skin assessments. So this needs to be done the first visit on admission in the clinical setting. And then if they're at risk, you keep going. Maybe once a quarter isn't enough for some of your patients for a review of their skin, another skin assessment. There should be ongoing inspection of skin that should be integrated in and documented into the care regime daily to ensure that changes in the health status of the skin integrity are identified. Our CNAs are precious to us. Are there any CNAs on this? Did anybody say that they were a CNA? CNAs should be here also. Unfortunately, my CNAs don't get to come because they're working at the bedside. CNAs need this training. So somebody really needs to take this information and help them. And I have a note here for you. When there's a facility-acquired skin tear, you want to ensure nursing does a new head-to-toe skin assessment and documents that on that skin tear on a regular basis. And the reason is we did have a building that got an F tag for that. It cost them $3,500 because there was a skin tear. And then they didn't show that a recent skin assessment had been done. The skin assessment wasn't documented. There were no notes about the status of that skin tear. It was just mentioned. So I see a reason for not documenting, but that's not good healthcare. We have to document. And because of this, it cost them, because of the lack of documentation and further assessment for the skin tear, it cost them $3,500 plus a plan of correction, which means they had to go back and do all the education, or should do all the education that I'm giving you today. So key considerations for skin tear management, key considerations, prevention. Look at this. They're preventing skin tears by having arm protectors on this person. They're preventing skin tears on the legs in this ambulatory person by having leg coverings on these people. So you want to do your assessment on admission, any significant change in health status. You want to have a fall prevention risk assessment process. Hopefully your therapists are working with you on recognizing the people that are at risk for falls and having fall prevention put in place. That's a big, big deal. Be sure you've got that fall prevention going on in your environment, in your clinical practice. You want to protect from self-harm, such as itching. Older skin, as it dries out, it gets itchy, and you want to make sure you're putting on enough moisturizer, and we'll talk about that in a few minutes. You want to pad the furniture and equipment. Particularly if this is repeated, look at these. This is a great place to get skin tears, is from the foot pedals and the leg rest on the wheelchairs. So some people hit themselves on this metal, and it gives them a skin tear on the foot and or lower extremity. So you want to ensure that residents wear the proper footwear and protective clothing, such as long sleeves or pants or knee-high socks, or even these arm coverings that you're seeing for people who are at risk. You want to teach your patients a little bit about their skin tear awareness to help prevent skin tears. They need to have plenty of fluid. This is important. We do not keep our long-term care people hydrated as well as we need to because they're not thirsty. They say they're not thirsty. They may have their coffee or tea, but that's all they want. So we have to gently but firmly push fluids on the people that it's appropriate for. Some people it's not appropriate to push the oral fluids, but some people it is. And we want to make sure that we do that. Again, keep those fingernails short. Avoid wearing jewelry. If you have rings that are high, we need to not wear those. If you're going to be in healthcare, we don't want to wear those. It's not appropriate for healthcare. And you want to look at their bathing routine. bathe less frequently. I'm an older adult. I'm not going to tell you how often I bathe, but I don't bathe every single day anymore because it washes off all of your protective oils. Now, every bath or shower that I do have, I put a layer of protective oil all over me, just the way you should be doing oils or moisturizers on your patients and residents after every bath, shower, be it bed bath, be it a shower, however you clean your patients. We want to optimize their nutrition and hydration. Again, we want to remind them of fluids. We want to adjust their bathing routines, less frequent, shorter times of water exposure, because that causes maceration, making it more fragile. And you want to use pH neutral soaps. This is very important, and avoid topical steroids when you can. When you can. And this is an article that talks about the twice daily skin moisturizing is more effective than the routine care. And they found that they had 50% lower skin tears, lower amount of skin tears when they put the moisturizers on the people that were having the skin tears twice a day, or not, no, excuse me, in the building, not just the people having skin tears, in the entire building. So the conclusion from this research was that routine skin moisturizing, are you doing it frequently enough, and are you using enough moisturizer, is recommended as one component of a prevention program for skin tears among aged adults residing in long-term care facilities. So the types of products that you want, and if you're a woman or a man, but usually women do this more often than men, but I don't want to be disparaging to our guys because sometimes they do, and I love it. I make my husband do a little bit of this. And that is we take care of our skin by using moisturizers and other types of products. These products that we use in the esthetician industry that's used in to help keep your skin looking younger as you can. They're emollients, humectants, and occlusive. Petrolatum, Vaseline is an occlusive. Humectants, these draw the moisture from the dermis into the epidermis, and emollients, they trap the moisture to help prevent water loss. These are the kind of products that we need to be using. Don't get a big jar of that yellow lotion that you push on, things that you pump out. That yellow lotion bottle has a lot of alcohol in it. And all of these products that move really smoothly and they're nice and thin, almost all of them are thinned with alcohol. These are the products you want. Which type of products are you using on your patients and residents? What's important is that we maintain the lipid structure. I'm telling you, as we get older, that you begin to lose this lipid structure. And so we have to support it with these 3 elements. That's what's going to support the lipid structure of the skin so that it doesn't, and when they have incontinence, they mess up this stratum corneum, this top layer, it opens up. It opens up. And then all of this begins to happen when that stratum corneum opens up like this, that inflammation, you see that red inflammation on your people. This is what's happening. The stratum corneum is broken. And now the moisture is evaporating out. So we have to close that up and keep it closed and try not to let it open to begin with, even when people have incontinence. Now, you're wondering, all right, Pamela, why do I have to learn a skin tear classification program or system? So you can communicate. So you can communicate the severity. So the best practice is that we learn to document for all of our etiologies. We just haven't been documenting well because they've been no one to teach us. But now we have somebody to teach us. I'm not talking about me. I'm talking about the Skin Council, the Skin Integrity Council. So the best practice to learn the document the severity of the tissue loss. That's going to help you with your care planning. You want to know, can the skin tear edges be approximated? I'm looking at this one, and the answer is nope. There's this is it. All of this is still open. So here's what's left of the flap. The flap is part of the flap is gone. What's the depth of the skin tear? Is it partial thickness or full thickness? The overall condition of the wound bed. That's going to guide some of your wound care interventions, and the patient or resident's overall clinical status, their goals, and their preferences. So this is it. This resource has been provided for you. This is how you type your skin tears. They are type 1, or type 2, or type 3. The type 1 is where you are able to take that flap and gently move it back into position where the entire flap is back in position. You may still have the area where it was torn, of course, and that's where you're going to be sure that you protect that area, but not with steri strips. We do not use steri strips on skin tear. No cross line go through it. Big 0, cross line goes through it. No steri strips. This is a partial tear. I just showed you on the other a partial lap, so it can't be repositioned to cover the the wound bed, and this is a total flap loss. So that's a 3 is a total flap loss. So once again, this is so easy. We have a type 1 skin tear with no skin loss. You can reapproximate the flap. Type 2 skin tear, partial flap loss. You lost part of the flap. You can't put it back in place. And a type 3 total flap loss. Total flap loss. And yes, you can use this recording to play at your CNF staffing. And it would do my heart. I have goosebumps just thinking about it. It would do my heart incredible good if I knew that you did that. And yes, you can, and please do. Our CNAs are precious to us and to our patients and residents. So a skin tear flap is defined as a portion of the skin, the epidermis or dermis, that is unintentionally separated partially or fully from its original place due to shear, friction, and or blunt trauma. This concept is not to be confused with tissue that is intentionally detached from its place of origin for therapeutic uses such as surgical skin grafting. So this is showing you a partially separated flap right there. So your assessments of your skin tear, what caused it, what's the anatomical location, and how long has it been there? Same thing with wounds. You want to know how long these wounds have been here. The longer a wound has been open, the longer it's going to take you to get those cells to gear up and do what they're supposed to do again. So you want to get those wounds, get them going as soon as you can. You want to look at the dimensions of that tear. You're going to write down the dimensions. There's not, if it's a partial skin tear, a partial thickness skin tear, there's not going to be a lot of depth. The wound bed characteristics, is there viable tissue or non-viable? The amount of exudate that you might see, the presence of bleeding or a hematoma, what's going on around that skin tear, what's the peri-wound area look like, signs and symptoms. You're looking for signs and symptoms of infection and any of the associated pain that goes along with skin tears. When they're partial thickness, they're very, very painful because the dermal area has been exposed. We look at our treatment, and this is a skin tear decision algorithm that's been provided for you. So this is where you have your skin tear. You're going to control the bleeding and do your assessment. You're going to cleanse that wound, and then you're going to classify it. And you're going to classify it as a type 1, type 2, or type 3. And then your goals of treatment are here. And it's the same goals of treatment for any other type of wound. You want to try to treat the cause. You want to implement prevention protocols. You want to do moist wound healing. You want to avoid trauma. You want to protect that peri-wound skin. You want to manage that exudate, avoid infection, and control the pain. You want to control bleeding, and usually we can elevate or put on pressure to control most bleeding. So we want to also, we may use dressings that will help if you're having, and these skin tears can be very bloody sometimes. You can go get you some calcium alginate, and that'll help with some of the superficial bleeding. Now, not arterial bleeding, but if you're having superficial bleeding, your calcium alginates will help the coagulopathy process so that the person will stop bleeding. And then the calcium alginate can be dampened and taken out of the wound bed. You want to cleanse and debride if debridement is necessary. You want to irrigate the wound well, remove any residual debris or hematoma. If you've got a bloody little glob in there, it's going to have to come out. Gently pat the surrounding tissue dry to avoid further injury. If the flap is present but necrotic, it might have to be debrided. And if you need debridement, then you need a nurse or a provider or a physical therapist that is licensed to do, if you're going to do sharp debridement, if you're going to cut something off, that's sharp debridement. Whether you cut it, use a scalpel, use a curette, that's sharp debridement. And that's going to require somebody that has the licensure to do that type of debridement. So flap, if it's viable, you're going to reapproximate it, and then you're going to put a dressing over it. You want to ease that flap back into place using a glove finger or a dampened cotton tip applicator. You can use tweezers, be very, very careful, or something like a silicone strip where you can catch it and then pull it where you need it to go, but be very careful with that. So now very quickly, we have a few more minutes left. Oh, we're doing great here. All right. What I want you to do is tell me what type skin tear is this. Please put it in the chat. Is it a type 1, a type 2, or a type 3? Look at that flap, where it went. And what we see here is outstanding, Nelson, outstanding, Ashley and Rachel, type 1. Thank you very much. All right. So our treatment of skin tears, you got to preserve the flap. You got to preserve the flap, especially on acute skin tear. So you're going to also have to maintain that peri-wound area, make sure it doesn't get excoriated. The term excoriated means scratches. Skin tears, when they first happen, they're very, very wet. There's an inflammatory process sets up immediately. So skin tears are usually wet wounds to begin with. So you want to make sure that you have a good dressing that's going to absorb if you're still having the wound to drain. So you want to reapproximate that flap to the wound edge. Now, you do this without stretching the skin. This is gentle. We don't stretch the skin when we're putting the flap back in place. You want to reduce the risk for infections by having a good dressing on top. You don't put on prophylactic antibiotics. We do not put on prophylactic antibiotics. We do not put on prophylactic antibiotics. You not put on triple antibiotics. You just don't, because we all do it. We used to do it. Everybody did it. We need to be careful with our topical antimicrobials also under the stewardship for antibiotic use. You want to let's see. Oh, we're going to use the appropriate wound healing practices for all wounds, which is moist wound healing, of course. Now, you see where this arrow is, and this is an old slide. These are nurses back as far as 2007 that knew how to do this. This is a skin tear. The pedicle is the piece of tissue that holds that skin tear, the flap in place. So a pedicle is right here, and they're telling the next nurse is going to change this to pull this off this way from where the date is, to pull it from the pedicle base towards where the skin tear originated. If you pull it this way, you are going to finish pulling off the skin tear. We're going to come back to this again. So you want to manage the inflammation and infection. And these are painful wounds. Your patients are going to be as stoic for you as they can. Be aware, these are painful wounds. And do not undertreat pain and do not dismiss their pain. So wound inflammation from trauma should be distinguished, of course, from wound infection. This is an acute wound. This is inflammation. This is not an infection. And this is a 2 to 3 day skin tear. You expect to see this kind of stuff. So wound infection can result in pain and delayed wound healing. So we want to make sure. And in the document, there is a wound care products in one of the documents for fragile skin, and that's the page that was on. You want to make sure they have their immunizations. They probably had them when they came into your building, or once they got into the building. You want to make sure they have their tetanus shot, especially if they haven't had one for a while. And again, edema adds to skin tear risk and healing complications. And this is a 2-day-old skin tear with the associated inflammation that you see with an acute wound. You want to consider the moisture balance and exudate control. They can be dry wounds, but there can be circumstances where they're wet. And oftentimes an acute skin tear is wet. And if the skin tear becomes infected, any wound that becomes infected, they usually get wet again. The moisture balance is essential to help promote the healing and to protect that peri-wound area from maceration. You don't want to extend this wound because of maceration. You want to observe the volume and the viscosity of the exudate. If the exudate starts thickening up, you've got a problem. And you want to think about that for getting your topical wound dressings. And there are some dressings you should use and some you should not use. And I'm going to talk about those in just a minute. So skin tears are acute wounds that with good wound healing interventions by the clinical staff, they should close in 2 to 3 weeks. You want to make sure that all the potential factors that could delay healing, such as their blood glucose is under control, there's no peripheral edema, that they have good nutrition, good protein on board. Any of your wound patients and elders, any of our elders, I know we're trying to feed them protein. They almost every single one of them need some type of protein booster when they have a wound. If they are older adults in your building, even though they're eating their chicken, they still need protein boosters when they have a wound. The larger the wound, the more protein that you might consider giving them. You might give them a couple of cans or containers of protein fluid, maybe in the mid-morning, maybe the mid-afternoon, and then they have their meals the other 3 times of the day. All people with large open wounds that are elders need extra protein. So compression could be considered if there's a lot of edema in the area. And it could be a skin tear near, say it's a venous leg ulcer. Well, you've got compression already under control. We're going to have compression on that venous leg ulcer. I'm sure y'all have compression on every one of your venous leg ulcer wounds, and it's the appropriate compression and not one sleeve of tube grip. One sleeve of tube grip is not good compression. You need at least two. So before applying compression on the lower extremity, a full leg assessment, including vascular assessment, your ankle brachial indices should be carried out. Now, I don't see our buildings doing ABIs, although I don't know why. It's not a super expensive piece of equipment. I've taught nurses and therapists all over this country how to do ABIs, but we don't do our own ABIs. I don't know why we don't do our ABIs. If I'm in your building, I'm going to have my own Doppler, whether you have your own Doppler or not. I don't do any lower extremity wound healing without an ankle brachial index done first. I have to know what the blood flow is, even if it's a skin tear. Even if it's a skin tear, you need to know what your blood flow is. Wound care products, you want to control bleeding. Your alginate may help with the minor bleeding. You want the dressings to be easy to apply and to not cause trauma taking them off. Silicone dressings are the best, with either the silicone tape around the edge, or say you're using a foam. Most of our foams now have a silicone interface, so it will be gentle when it comes off of these wounds. It's really nice if you can get silicone interfaces for some of these wounds. You don't want to cause trauma on removal. No adhesives. Use silicone tapes and borders. Paper tape is okay. That's what I used to have to use years ago. But now we have silicone. We even have a silicone tape that comes in little strips that you can take off as many strips as you need for as long as you need. Silicone, silicone, silicone on the population with fragile skin. You want to provide a protective anti-shear barrier. You want to optimize the physiological environments with moisture, bacterial balance. It needs to be a nice warm environment. The cells like to move in a warm environment. They shut down when they get chilled. They go, I'm cold and I'm not going to move until it warms up around this place. And it takes those wounds hours to thermoregulate the temperature back up to where the cells will move. You know, most of the wound healing takes place while the people are asleep at night, when we're not disturbing anything. And when you go to bed at night, your body upregulates your healing opportunities. Your parasympathetic system kicks in. Your sympathetic goes to sleep. Your fight and flight goes to sleep. That's when most of our healing takes place and regeneration takes place, is during sleep, which is one of the reasons it's so critical that your patients be able to sleep also. You want to provide, so that's it. You want it to be non-toxic, cost-effective, all of that kind of stuff. All right, let's look at this. This is another skin tear. Would you please look at this? And can you identify this as a type 1, a type 2, or a type 3? 1, 2, or 3. All right. Yes. It is a 3. There is no, and somebody said 2, and I can understand why you would say that, because it's hard to tell in this light-skinned individual that the entire flap is gone. So you would be able to tell this better in person, is my point. So the type 3 is the right answer. Outstanding. Outstanding. All right, skin tear treatment. Number 1, cleanse. You're going to rinse it with warm water or normal saline. You might clean it out a little bit with a gauze, lightly with a gauze. You're going to gently put that flap back in place. Get those edges as close as you can to closure. Use that moistened cotton tip applicator to help you gently shove that. That's the way I do it. Some people might choose to use pickups, maybe pull it back in place, but you do have to be careful that you don't pierce that skin. You want to balance the moisture, cover with a non-adherent layer. You want something that's not going to adhere to that piece of skin. Perforated silicone or impregnated gauze. You want to absorb and protect. Some kind of a gauze pad. Some people, in this document, they talked about ABDs. ABDs are not my favorite because they really do not absorb. The exudate sits on the skin is what it does. There's a little absorption, but most of it with the ABD pad, it just sits there. They're not really good for what we need them. We need super absorbers or foams. Foams are super absorbers. If you're trying to wick away moisture, trap it in the top of that dressing, you need foams or super absorbers. Those are the only 2 categories that track that exudate up into the top of that dressing and hold it there so it's not sitting on that wound bed. Let's see. Yeah, super absorbent, non-adherent to absorb blood or serous drainage if needed. Now, to hold something in place, you can use rolls, gauze, elastic bandage, stretchy net to secure it. Do not use steri-strip, hydrocolloids, or thin films. Do not use steri-strips, hydrocolloids, or thin films. And if you're going to use adhesives, use silicone. Use silicone. So we do not do this anymore. I did it. We all did it. We trimmed off those steri-strips as they came up because if we pull the whole thing off, we gave them another skin tear. So we now know, have it in the literature, that hydrocolloids, thin films, and closure strips, which are your steri-strips, and stitches are not appropriate for most skin tears. This is now in the literature. Are any of y'all still seeing? I'm not asking if you're using them. I'm just asking, are you seeing steri-strips still used on skin tears? Please say yes or no. I'm not going to be surprised with the yeses. I'm going to be thrilled with the no's. Okay, so we're seeing some yeses and some no's. So sadly, yes. Okay. So some people are getting the message and some aren't. And those who aren't, here you go. That's what this is for. It's to make a difference. And thank you so much for letting me help to make a difference. Proper tape utilization. So again, avoid adhesives, apply the tape without tension. Anytime you're putting tape on skin, most people are allergic, not to the tape, but to the applier of the tape, because they pull the tape tight or they pull the dressing tight. They pull the skin tightly. You don't do that. You lay it on. Just lay it on. You don't pull anything. So apply the tape without tension after applying a skin barrier product, particularly on that peri-wound area. Use adhesive remover. If you can't get it off of this fragile skin, please do not pull the fragile skin to get it off. Use an adhesive remover. They're not expensive and they're easy to use. You want to stabilize the skin using gentle low tension in the direction away from the attachment. So here's the pedicle right here. This is my initials. This is the date it was done. We need to be putting dates. Now, I made that up. I want you to know that. I made that up to show you. But we want dates on our dressings. I know some people don't want to put dates on their dressings, but it is the practice consensus that we put dates on our dressings. Our initials, in case we need to go back and say anything about that dressing. You use this dressing, but now it's doing this. How about if we use this dressing? So you want to know who's doing your dressing changes. You want the, again, you don't want to pull from this direction. Again, here's your pedicle. So that means that I need to take this off in this direction and not peel back from the other direction. So consider, just like this, drawing an arrow on the dressing to indicate the direction to remove that dressing, and then date and initial the dressing. And this again, this nurse, I love her. Love her. Look at this nurse. Isn't this fabulous? Remove in this direction, she says. I just thought that was just absolutely wonderful. Go this way. And so that's what they're showing here, taking your tear and moving it back where it needs to go, then putting your dressing on. And then when you take it off starting at the pedicle so you don't tear the rest of the skin tear off. Try not to use adhesives. Here's using a gauze wrap. Here's using a stockinette. Here's using a netting. There's no reason for tape on the skin in general. When it's the arms and legs particularly, we have other things that we can use. This is important for people that are older, for our elders, for people on long or high courses or doses of steroids. Use the gauze wrap or stockinettes or flexible nettings. This is the skin tear product selection guide that's in one of the documents that you have. And it talks about the different products, the indications, and the comments about these products. So I'll put that in there for you to study that. And this comes from The Art of Dressing Selection, a consensus statement on skin tears and best practices. And again, these products this is from this document right here at the very bottom. It says products not recommended, hydrocolloid, transparent film, closure strips due to their aggressive adhesive to the skin. May not be all inclusive of all products, just a guideline of representation. And this is from Sharon Baranowski and LeBlanc, who is, I think she's out of Europe. So your treatment review of acute skin tears. So again, cleanse it with normal saline, control that bleeding, remove clots and debris, approximate those wound edges, and best practices again supports that skin flap should be approximated to the extent possible, taking care to keep that pedicle intact. This is the pathway to assessment and treatment of that skin tear. And it talks about that patient with the skin tear. And the first thing you do is you look at the general health. You want to treat the cause. Then you go to your local wound care and with your atraumatic, there it is, atraumatic dressing, atraumatic, something that's not going to stick. Oh, excuse me, a patient-centered concerns. We have to go, number 2 is over here. I'm sorry, all the way to the right. And then we come back to your local wound care. So this is also in the document to help you with your algorithm. And then we go to what's called DIME. DIME is what we call in the wound management medicine industry. This is your wound bed preparation, DIME or TIME, time or dime. And this is for all wounds. Doesn't matter what the etiology of the wound. This is what all of us are doing. We're doing debridement. We're checking the tissue, whether it needs to be debrided or not. We're controlling infection and inflammation through topical antimicrobials. We're using moisture balance. We're using the right wound products. And then you want to watch the edge of the wound and make sure that it is advancing the way it's supposed to. So last one, oh shoot, dadgummit. All right, identify the skin tear type. Which skin tear is this? Yes, it's a 2. Oh, and Jacqueline, somebody just wanted to know when the recording was going to be available, and it's going to be available very shortly. All right, so dressing choices. We talked about that. Hydrogels, alginates, hydrofibers, lipid-based, foam dressing, soft silicone, non-adherent. That's what's important. Healthcare settings. You want to, in each of your healthcare settings, you want to implement a comprehensive skin tear reduction program, creates a skin tear in-house audit program. Where are they happening? What time are they happening? It's not about who's causing them. This is not about pointing fingers. This is about fixing things or trying to do the best we can do. You want to use a validated skin tear classification system, which you saw. All of you memorize this. 1, 2, 3. You've already done it. You've already learned it. Now go teach it. Create a skin tear consultative team with wound care, dietary specialists, rehab, your pharmacist. Can your pharmacist help you? Find your skin champions. Become or find a skin champion. Facilitate, coordinate, implement. You can't do this by yourself. It requires a team from your CNA who sees and touches the skin the most, all the way up to your providers and everyone in between. That dietitian needs to know what's going on. We all need to know what's going on. Your therapy team needs to help also. Requires awareness from everyone who comes in contact with that resident. You want to review and educate on the documents that you've been supplied at this presentation and design your skin tear program to facilitate bedside and clinical teams to transition from risk assessment to prevention and treatment of skin tears as needed. So find you a champion. And in summary, to manage and treat skin tears, healthcare providers must understand who's at risk first, just like for pressure injuries or any other wound, who's at risk, how to prevent these wounds from occurring. And we've given you some thoughts about this, how to managing these challenging wounds when they occur. We gave you some thoughts on this. And yes, we should be documenting them as wounds related to trauma. And this comes from Sharon Baranowski, one of the people that helped to write this document. You want to consider using the documents provided to educate everyone who handles the residents who are at risk for skin in your facilities, particularly those who are responsible for transfers, dressings, and showering. So that's your CNAs. God love them, and I do. And many of you nurses started out as CNAs, and then you became your RNs, your LVNs, your LPNs. So you're going to have a compassionate heart for those other CNAs. Revamp or start a structured skin tear prevention and management program in your facility. Track your skin tears according to the location on the body, the severity, the cause of the skin tear, where in the facility or room that skin tear occurred. You can decrease the number of skin tears and increase the quality of life for your patients and residents with a well-structured skin tear prevention and treatment program. Thank you very much. I went a couple of minutes over. I'm so sorry. You were wonderful. You're so interactive with me. So thank you, thank you, thank you. I'm so grateful. And Jacqueline, somebody has asked, how long is it going to be before they get the documents?
Yes, you will receive them tomorrow. So be on the lookout in your inbox tomorrow.
All right. Anything else anybody else wants to say? Did I see anything that I needed to look at, Jacqueline, in I glance over occasionally. Do I see
I
anything?
was,
You're so welcome, Ashley. Lewis, thank you for being here.
nope, all good. I don't see any questions here. Of course, y'all know where to find us. If you do have any questions, we will see you next month.
What's next month? It's the last one.
F686.
Ooh, F686. If you're in long-term care, be there or be aware. You want to be there for F686, and we'll have a good time. Take good care. Bye bye, everybody.